presume we don't know if she's there. You're live. All right, welcome everyone to the J. Flisher Centre for Public Mental Health Seminar on World Mental Health Day. I'm Catherine Sorsel and I'm the co-director of the centre. As many of you may know, our centre is a collaboration between the Department of Psychology at Stellenbosch University and the Department of Psychiatry and Mental Health here at the University of Cape Town. Ashok Kaji is my counterpart there. This is hopefully the first of many webinars in this format, and I'd like to thank Mahi Marks, who has put this all together. This was kind of a trial, but it looks like we've really got a number of people online, and I think there's a lot of interest in this particular topic. So this year's theme for World Mental Health Day is suicide prevention. And I think this theme has really made us all reflect on the landscape here in South Africa, which isn't novel. There's the same landscape in other African countries and globally. And it's really shown the gap in the research and work on suicide prevention. Even just looking to find speakers on suicide prevention in low middle income countries was relatively difficult. So we're really honored today to have Dr. Brenner talk to us on suicide prevention. So she is a rehabilitation psychologist, a professor of physical medicine and rehabilitation psychiatry and neurology at the University of Colorado. And she's also the director of the Department of Veterans Affairs, Rocky Mountain Mental Illness Research, Education and Clinical Center. So her primary area of research really focused on traumatic brain injury, comorbid psychiatric disorders, and negative psychiatric outcomes, including suicide. So we're really excited to have you here, Lisa, and I know it's really early where you are. It's she's in Colorado, so we really appreciate you making the effort here. And before I hand over to Maki, she's asked me just to let you all know that you can ask your questions in the chats, and we'll be able to see them. So welcome everyone, and we're really excited to have this conversation. So over to you.
Thank you. My pleasure to be here. Let's see if I can do this. Oops. Okay, I think that's the correct way. Somebody let me know if you can see my notes instead. Or you can't hear me. So my name's Lisa Brenner, and it's such a pleasure to talk to you all today. I'm not going to talk about brain injury today, and I am going to talk about what we do at the Rocky Mountain MIREC, also at the Department of Veterans Affairs, and try to talk a little bit about some of the efforts that we've undertaken lately that are both research-oriented and policy-oriented and implementation and dissemination-oriented. The first thing I have to say is that everything I'm going to present today is all me and not the Department of Veterans Affairs. These are all my opinions and not that of the US government. And I thought maybe a little bit of context would be important so that I've been working at the Department of Veterans Affairs and in particular the Veterans Health Administration for about 20 years. The VA is the largest integrated healthcare system, providing care at about 1,200 facilities, 170 medical centers, and 170 outpatient care sites. About 9 million individuals or veterans are enrolled each year. And in the United States, the Department of Defense is our really military, and the Department of Veterans Affairs, we have a number of benefits and services that we provide.
Sorry, we can't see your presentation.
Yes. Oh, you can't? Okay. Let's see. Oh, that's not good. Let's see. Let me go back to the beginning.
Yeah.
Can you see that? Okay. I don't know why that was doing it, but there we go. All right. Perfect. So the Department of Veterans Affairs is, thanks for letting me know. The Department of Veterans Affairs, as I was saying, really takes care of veterans, so individuals after they've served in the military. And, you know, about 23, can you still see? I hope you can. About 23% of veterans have, or all VA patients have a diagnosis and are treated for a mental health condition at a VA facility. Within the VA, there are something called MIRECs, Mental Illness Research and Education Centers, Each center is congressionally mandated and focuses on a specific area. Ours is on suicide and suicide prevention. And we have 2 sites, Denver and Salt Lake City. We have about 22 investigators and about 66 active studies. The way the center is organized is around cores, and really with the aim of preventing ideation and behaviors in the veteran population, though we really do believe that the work we do, and we've seen this to be true, has spread to civilian settings and actually to best practices here in the United States. And so we have different cores: education, research, clinical, admin, and data. And so the other thing that we do is that we have a very strong education dissemination core. And this education dissemination core really helps us get the work out there. And you'll see a number of products and things that we've been working on. So I tried, it was referenced about the research that's been done today in South Africa. And I have to admit that I spent some time reading this, and I have a clear weakness in this area. I'm not an expert in African or South African suicide prevention, so I want to ask for your forgiveness right away. But this is some of the research and resources that I did find. So the general rate of South African suicide in South Africa is about 11.5 per 100,000. But it does range, and there's some populations, and I read, some even higher than 25 per 100,000. I looked at an article that talked about 40 per 100,000 for individuals that are incarcerated. So about 11% of all non-natural deaths are suicide related. And on average, about 9.5% of non-natural deaths in young people are due to suicide. We know that numbers can be misleading. Also, we've certainly found this in the veteran population. The more time, energy, and investment of money and resource that we've made in actually looking at prevalence and incidence, the more we have found. And an undercount, much less continue to undercount. And there's many reasons that we have undercounts, and that's a different talk for a different day. I did find some nice resources on the South African Federation for Mental Health website. They don't want me using this without you ordering it, so they've got this little X in front of it. So I want you to know that this resource is there, which I thought was quite lovely, and that you can order it. In South Africa, I just mentioned this, but 9.5% of natural deaths in young people are due to suicide. I talked about that. The highest number of suicides occur in those that are 15 to 19. Girls tend to have the highest rate, which is actually interestingly different than the US. It's usually boys. And the common methods are hanging, overdose, shooting, gassing, and jumping from high places. High risk periods are weekends and end of the year. And they talk here about warning signs. And warning signs, this is a nice place to highlight the difference between warning signs and risk factors. Risk factors are epidemiologically driven factors that contribute to a population level increased risk for suicide. Warning signs, on the other hand, really are personalized thoughts, behaviors, and feelings that are associated with increased risk. So this is a nice resource that I did find. I thought it was also important to talk about kind of what maybe some of the drivers of suicide are in South Africa. And like in all countries, we share a number of these. So here is a study that looked at the association between traumatic events and suicide. So they looked at all kinds of traumatic events and ideation, which is thoughts, and attempts, which is behavior. And after they controlled for everything, sexual violence, having witnessed violence, continued to remain significant predictors of suicide attempts. So again, back to my previous statement, these would be more like risk factors, and the other things that are more personalized would be warning signs. Finally, this is a slide that really was starting to look at some social determinants. This is a large area of interest of mine, both social determinants and specific socio-demographic characteristics that may impact suicide risk. So this was done in Durban, South Africa, already a while ago. But those that were unemployed, men and younger age groups were at increased risk. Black people, followed by Indian, white, and mixed race people. and this whole idea of hanging method. And so it seems like hanging is a consistently high method in South Africa, which is different than in the US, where shooting and guns is really our lethal means that we're contending with, followed by self-poisoning, and you also have shooting and jumping that are methods. And those are all important because they give us ideas about how to work on prevention and environmental prevention. So the kinds of things like lethal means safety, having people bring old medications in to dispose of them safely, creating environmental barriers on bridges and buildings that are often used for suicide attempts. Folks might be familiar, for example, in the United States with the Golden Gate Bridge, and there's a number of different strategies that are in play there with netting, but also phone calls and phone numbers and phones, different things to try to encourage people to get help. I want to talk specifically about the idea of a risk identification strategy within the Department of Veterans Affairs. And as I said before, the whole risk identification strategy has been really contingent upon using research to facilitate policy change, to facilitate practice change, and circling back around. Previously, in the Department of Veterans Affairs, there was no one consistent way that we actually evaluated risk. And that includes, there was no standardized screening. So you saw that there's all those facilities, over 1,200 facilities, and everybody was doing it their own way. And there was also no standardized evaluation process. And I would say, you know, some sites were doing a great job, and some sites were doing less than great, and some sites just weren't doing a lot at all. So the decision, for a number of reasons, and was made to implement a standardized strategy. Now, one of the reasons was we have something called the Joint Commission here, and the Joint Commission, it actually highlights areas that medical facilities need to focus on and meet criteria in order to be accredited. And so this was very motivating and continues to be very motivating for healthcare systems, because the Joint Commission suggested and put a sentinel event alert out that detecting and treating ideation was serious, and it needed to be in place to receive accreditation. I know this is way in the weeds in terms of policy, but I think it's a nice example of how policy, national policy around accreditation, the rationale, which relies on research, and then how something can be implemented in a healthcare system can happen. And so the requirements from the Joint Commission really are there's 3 of them, and they include documenting individuals' overall level of risk for suicide with a plan to mitigate that risk, to use an evidence-based process of conducting a suicide risk assessment of individuals who have been screened positive for ideation. And the assessment must ask directly around ideation, plan, intent, suicidal or self-harm behaviors, risk factors, and protective factors. And then finally, that the third one, this is actually a typo here, the third one is really, doing screening, standardized screening within research and within clinical settings. And so with this idea that the Sentinel event and this strategy needed to change, in 2018, the Department of Veterans Affairs, this is how we make big policy change, a memo came out. And the memo came out in a way saying, we're going to do it the same way across everywhere in the VA, and this is how we're going to do it. So a little bit about what we're doing. So we have a 3-step process, and I think this is important to talk about. And I should say that I am not positive that this is the best process. In fact, we're collecting tons of data to figure out if this continues to be the way that we're going to go. But what we have done is implemented a 3-step process. This 3-step process, as I'll talk about, is implemented differently in different settings. But the first step is a screen. So again, I know that you probably all know this, but screeners are a way of identifying those who might be at increased risk. So, being able to do this fairly quickly, even in primary care settings. And then having a second level screener, and then moving on to, as JCO said, or Joint Commission said, this full comprehensive suicide risk evaluation or assessment. So the primary screen is the Patient Health Questionnaire 9, Item 9. You may be familiar with this. And so the item 9 was added to existing required screenings for depression and PTSD in all primary care clinics. And so VA, because we work with veterans who have a higher rate of post-traumatic stress disorder and depression, we had already had specific depression and PTSD screening in place, but we didn't have suicide-specific screening. And so this PHQ-9 is being used to identify those who may be at risk. A secondary screen is then implemented. We're using the Columbia screener, not the full Columbia, but the Columbia screener, which questions specifically about suicidal thoughts and behaviors with the goal of improving specificity and sensitivity. So if you screen positive on the 1 item, you get the Columbia, which is about 8 items. If you screen positive on that, you have a comprehensive evaluation. It's conducted via a new template that's been rolled out throughout the whole healthcare system. And it provides clinical information necessary to meet JCAHO requirements, but also to create a risk stratification, which was also required by JCAHO, and an associated disposition. So you have to have specific steps you're taking. Now, just a minute about acute and chronic risk. In the VA, we have adopted a 2-pronged strategy around risk stratification. It's high, intermediate, and low acute risk, and high, intermediate, and low chronic risk. And these are different things. Acute risk, as you might expect, means acute right now. And so this is an individual who has like acute high risk, would be somebody who's got intent, a plan, and an inability to keep themselves safe. However, within our population at the VA, we also have a number of individuals who are chronically on and off risk. And this was creating challenges for providers and for everybody, really, for researchers also, about how do you talk about this? And this would come up frequently on the inpatient unit. Somebody would be at very high risk acutely, they would be hospitalized, and then their acute risk would come down, but they really remained at chronic risk over time. So this allowed clinicians to say in individuals at high acute risk, and then they had come down over the hospitalization to low acute risk, they could keep themselves safe right now, but really that they had so many risk factors and or warning signs or potential stressors that they could move into the chronic, an acute state again quickly, and so they would get a chronic risk assessment also. And part of the way that we picked these measures, and I wanted to make sure you'll have this resource, was based on the clinical practice guideline. This is a new clinical practice guideline for the assessment and management of patients at risk for suicide. This was developed by the Department of Veterans Affairs and the Department of Defense. And these clinical practice guidelines, I should say, are based on all existing available evidence. They are not necessarily veteran specific because there just isn't evidence that's veteran or military specific. And this was just released this summer. And there's a number of resources related to it, and there's a number of issues covered in it. I'm highlighting the screening and evaluation part this morning, but there are a number of resources and literature that was reviewed related to post-acute care, pharmacologic interventions, non-pharmacologic interventions, community-based interventions. And what I should say is I was on the panel that worked on this last time and worked on it this time. We have come some way, and we actually have things that we can recommend now, which is a huge step forward based on evidence, but there's still a lot of research that needs to be done. So I want you all to know that South Africa and Africa is not the only ones who are behind the 8 ball on the research. We all are behind the 8 ball on the research. The way that clinical practice guidelines, these clinical practice guidelines work is that you're able to make recommendations based on all the existing evidence. And recommendations are graded, and often we think of weak as being bad, but here weak is actually good. To actually have enough evidence to be a weak 4 is actually quite good. And so we have, you can see the recommendations really range from insufficient evidence, which is really neither for nor against, weak against, strong against, weak 4, and strong 4. And in terms of the screening, you can see that there was weak 4 evidence that people should engage in universal screening, that systems should use the PHQ-9. There was the most evidence for that, so which we are. And that when you're doing this evaluation or assessment, you need to ask for about certain things, including ideation, prior attempts, prior psychiatric conditions or symptoms, prior psychiatric hospitalization, recent biopsychosocial stressors, and in the US, the availability of firearms. These were all risk factors that did actually have evidence available and were the strongest evidence in terms of risk factors. I want to highlight number 5 here. And it says, while it's an expected standard of care, there's insufficient evidence to recommend for or against the use of risk stratification to determine level of suicide risk. And we want to really highlight that there is not enough evidence yet around risk stratification, but it is 100% expected in terms of clinical practice, and people should continue to do it, but we do need more evidence for it. The implementation settings that this VA risk screening process is occurring in, and this is why it's so exciting, because often stuff is just in mental health, but this really isn't. This is in primary care, including home-based primary care, emergency departments, more traditional settings like outpatient, inpatient mental health care, inpatient rehabilitation, and medical surgical care settings. So as people come into the inpatient medical units and as they leave, in our long-term care facilities, so our community living centers, in sleep and pain outpatient specialty clinics, and also in mental health residential rehab programs. So really, this is engaging everybody across the VA in this process, which has been, I would say, a very interesting learning experience, to say the least. And we've had partners who are super excited to be in this with us and have really been super engaged. And then we have other partners who think, wow, this is, I'm a surgeon, and why are we doing this in surgical settings? And really trying to help people come along. And helping people come along has been an effort. And we have been using research to help guide us in this effort, this implementation effort, specifically work by Wandersman and his colleagues. And this idea that to actually implement innovations with quality, you need to use tools, training, technical assistance, and quality assurance and quality improvement. And so really what we're trying to do is integrate these 4 components to support implementation of this risk and evaluation strategy. And that, that if you want to achieve the desired outcome, that you need to increase the current level of capacity through using these things. And so not only was there a memo and coming out to say, like, this is what we're doing, but there's been a ton of resources. So one of the resources is tools, which is basic informational knowledge designed to organize or summarize or communicate knowledge. We use a SharePoint site that's available to all clinicians in the VA. There are guidance documents, requirements by settings, frequently asked questions, screeners, toolkits. I mean, tons and tons of materials here. We have had trainings. So this is really defined structured activity, more like we're doing today. We've had webinars, we've had online trainings, we've got ongoing trainings. We have role plays and other things that we have available for clinicians. And then one of the biggest things that we've done is had technical assistance. This has been individualized, hands-on approach to building the entity, or both the VA's capacity, but facilities capacity for quality implementation of this innovation. So usually you provide a training, and then you have ongoing TA, technical assistance. We have a weekly phone call every week where we are providing real-time collaboration with multiple stakeholders. And, we also have an email site that we try to get, like a group that we get questions on, and we try to respond to just in that same day. And so we have about 171 people are on each week on this tech assistance phone call from all over the United States. It's facilitated in part by having a facility champion who is really not necessarily responsible for making sure that the implementation happens, but is responsible for making sure that information is disseminated. And then we have the email support, and then we have these weekly calls. As you can see, we started this formal implementation. It took a little bit of a while to create the tools. It started in October of 2018. And at that point, there there was a lot of thoughts and feelings about actually implementing this. And you can see we were getting about 350, more than that, emails a day. And some of the phone calls, the weekly tech assistance calls at that time, there was about 400 people on these tech assistance phone calls. So lots and lots of great questions, lots of, change is hard, but we got through it. And as you can see, as we've implemented more and more of the rollout, the email volume's quite down. And we do, though, have a very consistent community that continues to attend for this tech assistance. The other thing is that we have quality assurance measures built in so that we can provide feedback to sites about how they're doing. Each of the note templates that have been rolled out nationally have specific components that we can pull information from. We have fallout reports so we can tell who was screened and should have been evaluated but maybe wasn't. And we have some pilot performance metrics around this. And so what this has resulted in, so this started in October, and just here's data from last, more than 1 month ago now. About 3,500,838 veterans have been screened. And this is only in primary care settings. This isn't all the data. The associated prevalence of ideation is 2.83%. And so part of why this is really important is people were worried that this would just be overwhelming to the system. It would be such a high number. It hasn't been. And then for those who are screened and go on, about 20%, almost 20% have a positive Columbia. So really 0.5% of individuals, unique veterans, actually end up receiving a comprehensive suicide risk evaluation. And as I said before, we're collecting data on this, and I will be able to share this with you in the future where we're at with it. In addition, we have a next step. VA has a really interesting and actually quite wonderful research availability of something called the Quality Enhancement Research Initiative. And what this does, it is a way to do further implementation dissemination research system-wide to see how implementation's going. And so one of our colleagues, Dr. Baraney, was funded. She designed a project using a smart design where facilities will receive feedback regarding how they're doing on implementing it. So an audit and feedback model. And then those who still have trouble after that will be again randomized to receive facilitation. So this is another really interesting project that will be happening over the next multiple years to see how do we really make sure that we can help full implementation of this to occur, and can we use an adaptive strategy and a smart design to make sure that happens. And it is a smart design, but smart design actually is a very specific research strategy that she's going to be using. Okay, and now for something completely different. When I spoke about talking today, there was kind of two topics that we came up with that might be different or interesting in terms of what's occurring there. And this is postvention. So we talked about risk and identification, really the front end, and postvention is what happens when somebody actually dies by suicide. So postvention activities refer to activities that reduce and promote healing after a suicide death, such as focused on supporting the family and friends of the loved one who died by suicide, begin the healing process for individuals who are dealing with the grief and distress, mitigating other negative effects of exposure to suicide, and preventing suicide amongst the people who are at elevated risk due to exposure to suicide. And I'm sure I'll say this another time before we're done, but we really see postvention as prevention. And we know that left without intervention, that after a suicide death, the rate of suicide amongst those who have died is higher. And we can't just leave it at that. We have to be engaged right away. And so just this summer, again, we have rolled out something called Uniting for Suicide Postvention. Many of the materials I'm talking about today, too, are available online, and that's a part of the reason I wanted to share them. And I'll give you the address at the end. And so here it is. Postvention is prevention. Again, this idea that really we need to be dealing both at the beginning and the end, and that by doing so, we will prevent suicide. And this idea that a suicide survivor can be defined in several ways, really by a person who's lost a significant other. But really, there are many other people that are touched by suicide death. And this is an area of research that is growing in the United States, really trying to get a better understanding of the impact on communities. And so it could also be someone that experiences a high level of self-perceived psychological, physical, or social distress for a considerable length of time after exposure to a suicide of another person. That being said, it can also be someone who is distressed when they lose a patient. And so a lot of the work that we've been really focusing on is taking care of the community of providers who are taking care of patients who die by suicide. And so these are some of the resources that it's Sarah Nazim who's in charge of this project from our center. As I said, all these infographics and everything are available on our website for you all to download if you're interested, and some of them are US centric, so I apologize for that. But this research has shown lately that for every one life is lost, 135 people are exposed. And so that in the US, that means 6 million people are exposed to suicide loss each year. And so this idea that, suicide can impact not just close family and friends, but neighbors, coworkers, hairdressers, gym instructors, bus drivers have been touched by suicide, with this graphic that is trying to show that, we often think of family, but we may not think of other people. And so that individuals actually, because of stigma, are often not talking about this. If somebody in their life dies by cancer or another health condition, we're often talking about it, coming together as a community, but not so much for suicide. So trying to provide survivors with resources that may help them understand the different feelings that they're having. And again, these are all online. And this idea of the occupational hazard of suicide, which I just mentioned, but in the US, an average of 12 clinicians lose a patient to suicide each week. In mental health, we often, think, oh, we shouldn't have suicide, or lots of providers think that, if you have a suicide, if you have one of your patients die by suicide, you did something wrong. And I often think about oncologists. Oncologists are doing everything that they can to prevent death by cancer, but often their patients die, or some patients die. Sometimes we do everything we can, and sometimes our patients die. And that, this is a normal part of practicing. I've had patients die by suicide, and that the personal grief reaction and influences on our professional identity, relationships with colleagues, how the system itself handles it can really impact our clinical work. So maybe not only, maybe we're not going to be able to do our best work with the next patient who comes in that's suicidal if we don't find ways to cope. So examples of professional impacts include either really feeling like you need to get peer consultation about everything, or wanting to kind of isolate yourself. You change your record keeping procedures. This one I think is really salient, that you decide that everybody needs to be hospitalized, and in doing so, minimize your patient's self-care abilities, that you reduce privileges of already hospitalized patients, that perhaps you are start to limit your practice so that you're perhaps not treating as high-risk patients. And I think, often people in the, people are in the United States, I should say at least, are very worried about liability. And so sometimes it can be hard to find professionals who are really knowledgeable about treating individuals with a history of suicidal behavior. Sometimes people leave the field, and sometimes people have more generic or intellectualized reactions. So this is several quotes from survivors, clinician survivors. I can only work with what people let me know, and this is often very limited. It made me have a difficult time trusting others and feeling confident doing what I do each day. And another provider said, initially I became highly cautious in my clinical work. I sought information, research, and tools to improve my practice. I became hypervigilant to issues surrounding suicide, violence, trauma, substance abuse, and risk assessment. It was as though I came to doubt my clinical acumen and my belief in the strong clinical instrument I've always trusted myself to be. Over time, this effect moderated, and I've been able to find a reasoned, informed path again. although unreasonable doubt still assails me from time to time. And I think, both of these quotes really highlight what can happen and then the kinds of supports that people can need. So the research suggests that there are factors that can moderate the impact of suicide loss on providers, including having had a prior suicide loss experience that you were able to negotiate, therapeutic relationships with your patients, but also other folks like consultants, the treatment context. So if you're seeing somebody individually versus a team-based approach where a whole team can feel that they have shared responsibility, and cognitive factors in terms of kind of how we personally interpret our world and attributes. And the big one here is support. So therapists that experience great distress after a suicide versus those that experience mild and moderate report having significantly less support from colleagues in their institution and had significantly higher fear of lawsuits and reactions of families. So we talk about in our center, because we do this work all the time, we're frequently working with high-risk patients and consulting on high-risk patients. This idea of never worrying alone, and having people, having teams, having outlets of people that you feel safe, obviously it's appropriate, but that you feel safe talking about cases with. And so given the prevalence and impact of suicide loss, it's important to support providers in the following ways. Setting the expectation that because we work with, here in this case, veterans who experience serious mental illness, we must embrace the reality that some of our service members and veterans will die because of the natural course of their disorder. Some won't, but some will. And what could have been done differently is not to be interpreted as what should have been done. This type of support is instrumental in promoting professional growth, in keeping people in the field and not having people burn out. And also this really hard piece of understanding the limits of our therapeutic power. I know my patients I feel really, really close to. I feel like we have a thing, our relationship. And when I've had patients die by suicide, it does shock a bit the kind of my sense of the relationship and my sense of what I can do. And I think really being honest about that with each other and preparing ahead of time is key. So the other thing that is available in these resources is having a suicide postvention planning. And specifically workplace suicide postvention plans. And this is just super important, this idea that you don't want to put things in place when there is an emergency or an event. And, we always talk about kind of being planful ahead for physical emergencies, environmental emergencies, and this is much the same, so that you would have a postvention plan in place in your institution, that you would engage in these steps, which include notifying, educating, uniting, outreaching, and sustaining, and that this process would be well known to everybody. And so, first of all, it would include notifying, which after receiving verification of a suicide, that you would coordinate immediate notification to employees, and that there would be a way that this happens that ensures that communication is factual, includes accurate information, and is done in a manner that is not stigmatizing or punitive to the provider. You provide information on, so this is the educating, providing information on common reactions following a suicide loss, suggestions for self-care, and resources for employees. And that you would be united with that person, as we talked about, kind of being in it together on teams ahead of time. We want to be in it together as teams after the fact. So consider ways to mourn collectively to promote healing, allow employees to come together to process the loss, to facilitate workplace emotional support, offer practical support like take time off and meal coordination to the family. Okay, and then outreach. Having a strategy in place ahead of time about how you're going to reach out to family members to offer workplace condolences, provide information about employee assistance programs, and target support to employees who are impacted by the loss. And finally, having a sustained presence, so planning and executing strategies to offer long-term support to facilitate this ongoing grieving process. And I really liked the quote from that provider where she said, I feel pretty good now, but every once in a while it comes back in that overwhelming sense on anniversaries or holidays or workplace events that may be challenging, and finding new ways all the time. So suicide postvention teams are multidisciplinary. They assist with the notifications of suicide, and they have responsibilities in providing support for the affected staff and making contact with the family. And this includes potentially making outreach phone calls, attending services or sending cards, facilitating in-person family meetings, and providing resources and referrals. They also provide long-term support as appropriate. We talked about that. And so there are a number of resources that are starting to grow out there. TAPS is a specific military resource for families, but the American Association of Suicidology has resources. The American Foundation for Suicide Prevention also does, as does Psych Armor. But this is an additional resource that can be used. I was too nervous to actually show a video, but there are, the website for this is just absolutely beautiful. And it's beautifully put together, has different sections for different kind of communities that might use it. And it has then tools and resources in there. There's also a number of podcasts that have been created that are available on the website and on like the Apple store and the Android stores that you can listen to. And I'll talk about our podcasts in a minute. And where this group is on Twitter, and they also are happy to consult via email. As you can imagine, it takes a whole lot of work to do some of this stuff. So we've really been partnering with tons and tons of folks, not just in our center, but across the Department of Veterans Affairs. And I just want to talk a little bit more about the center right now. We have a number of resources, as I said, that are available on our website. We do have a podcast, as I talked about, that's about suicide and suicide prevention. And that the resources there, in terms of the podcast, range from topics of postvention to assessment to risk identification to the Veterans Crisis Line. So really widespread. There's also specific focus on lived experience of suicide. So we have individuals who've had suicide histories, both themselves, family members. So really a broad ranging. So really want to encourage you to look at our website. We're super active on Twitter, and I myself am super active on Twitter. So I'd love to see you on Twitter. And this is the end of what I had to present today. And I know we have a little bit of time for questions. So I'm going to end my screen sharing and go to the questions area. Tell me if I'm not doing this right. I think I am on track.
Yeah, thank you, Dr. Brenner. You are definitely on track. Now we do have about 15 minutes for some questions. Everybody, you can see in the chat questions polls people sidebar window. When you select questions, you should be able to send one through. So please send us your questions. Yeah, while we wait for those, I would just like to remind everybody about our Hope Hike, the Hope Hike that will be hosted in Stellenbosch. As you can see, it is this coming Sunday. So if you are based in Cape Town, please join us. Yeah, and then also we launched a report this morning on the costing of mental health care in South Africa. So please go read that. It's very interesting. I just sent you the link over there. Entry URL to the Hope Hike. It's also now in your chat window. And we have our first question from Catherine. Dr. Brenner, can you see it?
Yes, I do.
Great.
So given the lack of research in South Africa, there's ample opportunities for yes. I mean, yes. I think that I think your question is, should there be more research, and So are there any difficulties with doing research in this area? I think that's, I just want to make sure I answer the right question. Catherine, I want to do right by you. I mean, I can talk. I think you're asking, are there difficulties in doing research? I think there's opportunities and difficulties. I mean, certainly, you know, there are the typical ones around, given the lack of research, yes, but okay, yes, it's okay. Thank you, Catherine. So yes, I mean, I think part of doing this is really breaking down stigma by doing the research, and it's such a sensitive topic. But there have been other topics in the past, mental health topics, health-related topics that have been also ultra sensitive, and lots of the sensitivity is really related to stigma. And so the importance in doing it is not only in the knowledge generation, but also in the actual process of doing it. I can say for like at the beginning, when we started doing our human subjects research, our IRB, so the review board for human subjects research, was so freaked out by our protocols. They were so afraid. You know, the idea that we would be seeing high-risk veterans really made them so afraid to approve anything. And so it's been a relationship with them over time to actually help them feel more comfortable. And that's just one example, I think, of some of the difficulties, though you certainly can get there. You know, the opportunities are, you know, I don't think I did an exhaustive review of what's been happening in South Africa, but I think if you're a researcher who wants to make a difference, there's a lot of room in South Africa. There's a lot of room in the US still to really contribute and make a difference. And, you know, that's been a really wonderful thing in terms of my career, is being able to kind of see the work that I do. It's so needed. It's so necessary that it actually does get adopted in ways that are surprising and wonderful. So go, Catherine. I say go, please go. Claire, in schools, how do you suggest we talk about suicide and self-harm for universal prevention approaches? Yeah. And so there is not a lot of data to suggest that, you know, that talking about suicide increases risk or behavior. And there are a number of programs in our schools that, and this is not my area of expertise, Claire, so you can email me too, and I can get you some more. But interestingly, I have 2 teenage boys, and one of them came home from high school and had a sticker on his notebook, and they'd had suicide prevention universal training. And you know, one of the big things that's been a focus is how do we help kids be supports to other kids. And you know, so some of it, I think, is that particularly we have a huge social media problem and internet problem. I would assume you have it there too. I don't want to assume, but that kids are exposed to so many things anyways. And if they don't have a knowledge base about what to do, it is even more frightening. And so really providing these resources. And I think there's a lot that can be built off of. Certainly, I want to say that I think there are cultural elements for different communities that need to be incorporated in these. But Claire, if you want to email me, I can also show you some what's been happening. Okay, Jared, thanks so much. Okay, you're welcome. I hope it's early in the morning, so I feel a little bit fumbly, but I think we did okay. Do you have more information on underreporting mental health? Yeah. Yes, and so, you know, I definitely think there's underreporting, and that we've explored lots and lots of different ways about try to get at this. People, it's interesting in the U.S. I think there's less, you know, there's growing acceptance of mental health and mental health conditions. But certainly one way we've gone about improving it is we have huge national health surveys that people complete that are anonymous. And so we have gotten some really wonderful data related to mental health and mental health conditions on platforms where people may not feel it's so stigmatizing to them individually. Your question about modeling for incidents for policy recommendations is so interesting. And, you know, I think we have done some of that, though not enough of it. And even without the modeling, we know that in the US, we do not have enough psychotherapists to actually meet the needs of everybody who needs treatment. And we have huge problems in the US, not so much in the Department of Veterans Affairs, because it is a large single payer system, but, you know, with insurance and different insurance plans in the United States and private insurance, mental health care continues not to be covered as well as physical health care. And so lots and lots of strategies are needed. And I can talk a different time or whatever, but I have a lot of interests around how do we increase access using things like the internet, web-based interventions. We have a study that we're doing right now where we have people have apps on their phone that it sounds a little bit big brotherish, but people are into it. I mean, it tracks people on their phone in terms of not their exact texts and not their exact steps and not their exact getting out, but like whether they have changes in their getting out behaviors, whether they're isolating, and we see them on a dashboard every day and then we call them. And I thought the veterans would hate it. I thought they'd think it's big brotherish. They actually felt like insanely taken care of by the fact that somebody was watching them and thinking about them and actually outreaching them. So, you know, I think some of this is also for those of us in mental health, we have very specific ideas. I have very specific ideas about what is helpful. And it turns out not everybody wants to sit in a psychotherapy session. And there's a lot of ways that we can explore taking care of people. Okay, Charles, what is the likelihood of parasuicide patient? Yeah, interesting, we don't use the word parasuicide anymore, but we do talk about lethality. And so, you know, I think there certainly is kind of two ways this can go, Charles. So one is this idea that, you know, there are individuals who maybe have some challenges in terms of coping strategies and use perhaps suicidal behaviors or, you know, and this gets into a whole other area of nomenclature, but use self-harm behaviors, let me talk about that, or self-directed violent behaviors for a number of different reasons. Sometimes it's with intent to die, but sometimes it's with relieving emotional pain. Sometimes it's with trying to communicate feelings. And that I'll go down that lane first. Certainly working with folks around distress tolerance. There's really nice research around dialectic behavior therapy and emotional regulation to help that cohort. And then there's another group who have increasingly dangerous suicidal events. And, you know, those folks are hard to help. And some of those folks may die by suicide in the end. But I think what we have also found to be even more challenging, and so in the VA, when we identify those folks, they have like really intense wraparound services. And that does seem to help. So suicide rates are going up everywhere in the United States. One group that the rates are going up not as quickly is those who are getting care at the Department of Veterans Affairs with those wraparound services. And again, happy to come back a different time and talk about kind of some of those wraparound services and what we've done. But you know, what really is vexing also, Charles, is we are terrible, and this gets to the question, Bix, I'm not going to say your name correctly, I'm so sorry, about is there a tool? No, there's not. We are horrible at predicting suicide risk, particularly first attempts. And so we are using all different things. So this more universal screening. We're also using some predictive modeling strategies in the VA. But this is an area that a lot of effort has been put into, and it is very hard to predict first suicide attempts. And actually the best predictor of a suicide attempt is previous suicide attempt. But for some individuals, particularly if you're using a gun, the first suicide attempt is the only attempt and it results in death. So we need big brains like all of yours to help us think about different ways to do this. I'm talking away here. I hope I'm on track. Can I share one thing really quick? Can I share my screen really quick? I'm gonna do it really quick. So folks, just wanted to show you. So this is what our website looks like. And so you can see that there's areas on it for researchers, educators, and clinicians. This is the whole Uniting for Postvention part. Look, it's actually working on the internet. It's a beautiful thing. There's all these videos and different strategies. I do want to show you one other thing. I want to go back and talk about education. Here, I want to actually go to clinical. Well, there was our podcast, but we have, I was talking about intermediate, high, and low risk, and acute and chronic risk. If you're interested in that all, there's tons of resources here that can be looked at. And this whole idea of therapeutic risk management is something we've spent a lot of time doing work on. So there's videos on therapeutic risk management. There's risk stratification tools. There's just tons of resources here. There's resources around safety planning. So I just want you to know that this is all here and should be easily accessible by you all to be able to take a look at all of this. What are the common myths about suicide and how can they best be addressed? Well, I mean, I think, you know, there's probably myths that range. Some of them certainly are culturally driven, and some of them are religiously driven. Some of them are about kind of people being not strong enough. I mean, I think there's all kinds of myths. And, you know, one thing that I really like to do when I'm working with patients or communities is find out what their individual myths or beliefs are. So, for example, in Colorado, we have a number of First Nation communities. They certainly view suicide and what it means when people engage in suicidal behavior very differently than maybe our African American communities and a more Caucasian community. So myth is, I think, a multi-pronged thing. And you know, one thing I was noticing in the literature from South Africa, because I was trying to kind of get a handle on stories. And there were some epi studies, but there were not very many qualitative studies. And I was trying to get smart fast. But trying to think about like the different cultures and different cultural values and how we can address those. And I didn't see as much around that, but I might have missed it. But I think that would be a whole other fascinating area, because then you could develop suicide prevention interventions that are community-based, based on the needs of the community. All right.
Okay, thank you, Dr. Brenner.
Very good.
I personally really enjoy that and find it really interesting. I'm thinking we're at the last of our questions, so I would really just like to thank you for your time, waking up so early.
So happy.
All the way from the US. Yeah, thank you so much.
Yes.
Anything?
And if there's things too that, no, just if there's things I'm gonna, you know, if there's things that people think that I can look at or read to get smarter about South Africa and the suicide prevention strategies and problems and challenges that you're using there, please reach out to me. I'm very interested in different cultures and different strategies. So I really appreciate you all being on with me today. And thanks for putting up with my terribly US-centric presentation.
No, it was perfect. Thank you so much. We'll make sure to follow you on Twitter. Anybody who has questions for Dr. Brenner can also reach out to her on Twitter. Yeah, thank you so much. Everybody seems to be very on the chat as well. So we hope you enjoy the rest of your day as we come to.
Thank you all. Have a good day.
Thank you so much, Dr. Brenner. Okay, goodbye, everybody. Thank you for joining us.
Yeah. Thank you.